I'm senior patient specialist at Saudi Patient Safety Center. Today we will hear from one of pioneer and one of the figure in medication safety in the kingdom. She is a quality consultant and Ministry of Defense Health Services, continuous quality improvement and patient safety department. She received her Bachelor of Pharmaceutical Science from King Saud University in Riyadh, and she graduated in 2011 with the Master of Science in Healthcare Policy and Management Quality from the University of Birmingham at the United Kingdom Health Services Management Center. She will talk today about technology and medication safety. Please welcome with me with Dr. Dalia Al-Ghamdi. Dr. Dalia, the floor is you.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. This is Dalia Al-Ghamdi, and I will talk today about technology and medication safety. So the topic today, it's about technology and medication safety. And we will describe technology trends undertaken in pharmacy-related setting, and we will outline how does technology affect medication safety with hearing and reading some scenarios in medication safety and medication error related to technology, highlights the benefits and recommendation of utilizing technology in enhancing medication safety. So technology trends undertaken in the pharmacy-related setting. At the beginning, before we go in further details, so medication error remain one of the most common cause of patient injuries in the United States with detrimental outcomes, including adverse drug reaction and even death. By developing a better understanding of why and how medication errors occur, preventive measures may be implemented, including technological advances. Potential methods of reducing medication error were explored. Technology can be an excellent aid in improving safety, medication administration, especially. Computer technology cannot replace human intuition, and nurse should be involved when implementing any new computerized system in order to obtain the most appropriate and user-friendly structure. So when we look at technology in the pharmacy setting, and the implementation of this technology in medication use system is widely accepted as a way to reduce adverse effect by decreasing human error. Technology examples include computerized order entry system, which is called CPOE, computerized physician order entry, clinical decision support system, which help us as a healthcare provider in understanding the decision that we need to take it for our patient regarding dosing, maximum, minimum doses, drug-drug interaction, drug-food interaction, robotic dispensing, and which we use it in the outpatient if we want to use it, profiled automated dispensing cabinets where we store the medications in a cabinet, and which having a special security system that help in controlling the medication. Smart infusion pump, which is essential for high alert medications and some of the oncology medication, barcode scanning of medication during compounding, dispensing, ADC restocking, and administration. So we can see here in this picture robots and carousels where we can store the medication, we can have our unit dose, where we can bring the printed label, and we will identify the medication for each patient. Barcode and digital imaging system and barcoding and digital system is very well known nowadays in preventing and minimizing medication error instead of having wrong medication or wrong patient medication. And this could be used in oncology, cytotoxic agents, and in preparing some identifying the barcode for specific medication. So by that, we will minimize the misidentification of the patient. Robotic and IV devices is also something we can see it in the IV room. We can see it in outpatient. It's a good technology that we can depend on in the highly complex hospital. You can see here the TPN and automated compounding devices, where we can easily prepare our TPN by programming the device and having the good technology in the place, instead of preparing each bag of TPN for each patient in a manual way that might lead to confusion at the time of preparation. So a small effort, big payoff, automated maximum dose alert with hard stops. As I told you at the beginning, that I will tell you some scenarios that will make us understanding that we shouldn't depend 100% on the technology and neglect the role of human healthcare providers in our hospitals. So preventable error with 3 other high alert medication, which are amphotericin B, methotrexate, and fentanyl, many of which could be prevented by another relatively simple strategy. An automated maximum dose alert with a hard stop. So hard stop versus soft stops. Automated alerts can be provide an effective means of communicating essential information about drug and patient clinician who prescribe, dispense, and administer medication. This alert intended to support the clinical decision support and supporting us in our clinical decision and safety and efficacy of drug therapy. Alerts are typically communicated through warning message pop up in the screen. So warning us that there is an issue happening with your order at the time you enter. This alert can cause either a soft stop or hard stop. Soft stop provide information to the clinician about potential drug safety efficacy problem and may offer alternative suggestion for the clinician to consider. However, minimal or no action or acknowledgement of the alert is required on the part of the user to proceed. Hard stop, it prevents dangerous harm to or harming our patient through the medication use process, either by prescriber or dispensing or administration. So it's the further is blocked when we have a hard stop. Hard stop may allow continuation of the process if significant action is taken by the user, such as requiring a prescriber to call the pharmacy to discuss the order. Studies have shown soft stop are often overlooked or quickly overridden. So it will not stop a healthcare provider who is insisting to make the mistake and without careful consideration of the warning for a variety of reasons, including alert fatigue and poor design of the warning. Hard stop and nearly hard stop have been shown to be much more effective in capturing the user attention and getting the user to change the we can see the stops us from this mistakes. So you can formulate
داليا
conventional
دكتورة داليا الصوت يقطع عندك، يمكن لو تقفلين الكام يطلع يكون إذا ممكن.
Thank you.
Okay.
So sorry for that. In a recently reported event, amphotericin B conventional was prescribed in a dose reserved for the lipid-based product, a patient with acute myeloplastic leukemia and recent bone marrow transplant developed pulmonary aspergilloma. Amphotericin, using a CPOE system, the patient physician entered the order of amphotericin B conventional 375 milligram every 24 hours, based on the patient weight, which is 75 kg. And the patient received 5 milligram per kg of amphotericin conventional, while the maximum dose for this product is 1.5 milligram per kg per day. What does it mean? That the patient is taking 3 times higher than maximum dose recommended for conventional amphotericin B. Within 3 hours of administration, the patient suffered of a cardiac arrest and died as a result of this mistake. During prescriber order entry, the drug a warning had popped up in the screen asking prescriber to verify the dose and did not exceed 1.5 milligram per kg. However, the CPOE system did not require acknowledgement of the warning or action by the prescriber. So what does it mean? This is a soft stop. The alert quickly disappeared after hitting the enter key and was bypassed without consideration. And the pharmacist also missed an opportunity to capture the dosing error. Although the screen accessed by the pharmacist when verifying the order revealed that amphotericin B conventional equivalent to fungizone had been prescribed, the pharmacist misunderstood the order, again, lipid-based product, and have been obtained a required approval from the infectious disease prescriber to dispense the ambisome. The pharmacy label that printed resulted in preparation of the conventional amphotericin B. The nurse who administered the drug did not notice the error, and she was not aware of the dosing difference between conventional and lipid-based form of the drug. Of course, she thinks that this medication is it's amphotericin, all of them are the same, there is nothing lipid-based product. Maybe she's not aware about the formulary items available in her hospital. Okay, numerous risk reduction strategies may have helped to prevent or detect this error, such as including brand name when prescribing the lipid-based forms of the drug. The computer alert should be with a hard stop for doses of conventional amphotericin greater than 1.5 milligram per kg. For both CPOE pharmacy system is a key strategies whose importance should not be minimized. Patient weight is requested and it's mandatory in all complete prescription. And if this does not occur consistently at the practice in your site, you may not establish a catastrophic dose. You will not be able to catch it. Limit for hard stop alert. Such can be designed to ensure an appropriate dose, but rather to force a dose. Methotrexate is a cytotoxic agent used in oncology, used in rheumatoid arthritis. There is a daily dose and there is a weekly dose. And as you know, in a daily dose, if it's used in oncology department, weekly dose if it's used in the rheumatology, and look at kind of problems that we might facing with this medication. So over a 4-year period, there is a 25 death and 48 serious outcome as a result of use since in 2004 that happened, and it was reported in ISMP. Many due to daily dosing. The most recently reported event happened at a compounding pharmacy, but the same type of error has happened in hospitals. In this recent case, the compounding pharmacy received a telephone order to prepare an oral liquid preparation of methotrexate 12 milligram per ml with instruction to administer 6 milligram, which is 0.5 ml once a week for a 19-month-old child that with a juvenile dermatomyositis. A pharmacist transcribed the order incorrectly, entered into the pharmacy computer with a dosing frequently of daily dosing rather than enter it as weekly dose. The pharmacy compounded the solution using methotrexate powder, labeled the medication and the instruction to take 0.5 ml daily instead of weekly. The pharmacist handling the order was unfamiliar with the methotrexate dosing and did not recognize that a daily dose would be toxic. Also, pharmacy had filled a prescription for oral liquid methotrexate before the event. The child received a daily dose for 7 days before an error was noticed by the prescriber. The child was undergoing diagnostic laboratory tests to determine the adverse effect of this overdose when an event was reported to Institute for Safe Medication Practices. Again, this is an ongoing error that could be easily to be prevented by hard stop in the pharmacy computer for daily dosing of oral methotrexate. You can put it, if you have oncology indication, you can leave it as once daily. But for rheumatology indication or other related disease, it needs to be once weekly. Or filling a frequent oncology order for daily doses without stop date after 5 days or less. Fentanyl is a narcotic medication, controlled medication, high alert medication. So we need to focus in that kind of medication or this type of medication. Fentanyl, a lot of error happened with it, and it was reported to the Institute for Safe Medication Practices in 100 acute care newsletter. About a quarter of them are relevant to IV dosing error. The most recent dosing error occurred within 2-month-old infant. So you can see the problem is related mostly for pediatric patient, where the weight is important in order to calculate the dose for this patient, type of patient, or patient who is having 40 kg or less body weight. Okay. This baby or infant admitted to the hospital for pyeloplasty, and the anesthesia team started a fentanyl infusion. It should be 200 microgram in 20 ml of 5% dextrose to be delivered at 1 microgram per kg per hour during the surgical procedure. What happened that the patient received the of fentanyl less than an hour. The interfere here had been misprogrammed to deliver 1 microgram per kg per minute instead of 1 microgram per kg per hour. The infant become hypotensive as a result of short respiratory suppression, also short interval but tolerated to the procedure, and was breathing spontaneously after surgery. Numerous risk reduction strategies could help prevent infusion pump programming error, but one key intervention in this case include a hard stop during pump programming that would not allow the programming of such a catastrophic dose to continue. Hard stop in this case would have required programming of the pump in accordance to the approved dosing guidelines. So the errors mentioned earlier related to amphotericin B, methotrexate, fentanyl, in which hard stops would have protected patient from harmful medication error. While some clinicians may complain that hard stop potentially delay order completion or slow the dispensing and administration process. The intent is to allow for a brief period of investigation to ensure safety. Clearly, for drugs like amphotericin, methotrexate, fentanyl, the risk of potentially fatal dosing error for outweighs any risk of slight delay in therapy. Doesn't mean anything that if we will delay the therapy in order to assure the correct dose is administered or reached to our patient. Another barrier may be that some clinicians find hard stop objectionable, noting that decision support should not replace the clinician responsibility for patient. So when relatively simple action like placed hard stop could prevent harmful event and the clinicians do not implement them, they are clearly not upholding their responsibility or accountability at their work to keep patients safe from unreasonable risk. While organizations need to address any clinician concern with hard stop and make every effort to minimize an unintended effect, there is a suggestion that organizations should place issues of hard stop for certain drugs, including three described medication, which is amphotericin and methotrexate and fentanyl, preventable clinical situation in the top of their safety agenda. How does the technology affect medication safety? Technology and medication safety and medication use system are meant to support human cognitive process and thus have a great potential to combat the shortcoming of manual medication system and improve clinical decision and patient outcomes. Accomplished through precise control automatically to help the user respond appropriately, and through the collection of critical information and alert to make the user aware of the potential errors. Information technology to support clinical decision-making and not replace activity, but rather change it, often is in unintended or unanticipated ways. Instance of misuse and disuse often to work around technology's issues and new sources of errors after technology. So we are used to talk about medication error in the medication use process, either dispensing error or administration error, prescribing error. However, with the technology, you will identify a new type or kind of error that we are not aware about it previously, that have been well documented. Errors can also be caused by over-reliance and trust the proper function of technology. So technology can occasionally malfunction, misdirected the user, or provide incorrect information or recommendation that lead the user to change a previously correct decision or follow a pathway that lead to an error. So over-reliance in technology is an area that we as a human fail on and trust the technology without getting back and think biologically about some of the product coming from this technology. So over-reliance in technology can result in what? In serious consequences for patient. So our patient safety, it might be jeopardized or affected. So Institute for Safe Medication Practice in Canada highlighted human over-reliance in technology based on its analysis of an event reported to a Canadian national reporting system. They discussed two related cognitive limitations, automation bias and automation complacency, or over-trusting of the medication, of the technology. Instant description: an elderly patient was admitted to the hospital with a new onset seizures. Admission orders included the anticonvulsant phenytoin, handwritten using the brand name Dilantin, 300 milligram orally every evening before the pharmacy closed. A pharmacy staff member entered the Dilantin order into the pharmacy computer so that the medication could be obtained from an ADC inpatient care unit overnight. In the pharmacy, computer medication selection for order entry was performed by typing the first three letters of the medication's name, DIL, D-I-L, in this case, and then choosing the desired medication name from the drop-down list. The computer list contained both generic and brand name. The staff member was interrupted while entering the order. When this task was resumed, diltiazem 300 milligram was selected instead of the Dilantin, or which is phenytoin 300 milligram. So in the patient care unit, the order for Dilantin had been correctly transcribed by hand into a daily computer-generated medication administration record, which was verified against the prescriber's order and co-signed by a nurse. The nurse who obtained the medication from the unit's ADC noticed the discrepancy between the MAR and the ADC display, but accepted the information displayed on the ADC screen as correct. The patient received one dose long-acting diltiazem 300 milligram instead of Dilantin. So until now, we are receiving wrong information as a result of using technology or depending in technology. The error was caught in the next morning when the patient exhibited significant hypotension and bradycardia. Automation bias and automation depending on the technology. The tendency to favor or give greater credence to information from technology, for example, automated dispensing cabinet display, and ignore manual source of information that provide contradictory information, handwritten entry in the computer-generated MAR, even if it's correct, illustrates the phenomena of automation bias. Automation complacency is a closely linked overlapping concept that refers to the monitoring of technology less frequently or with less vigilance because of lower degree suspicion of error and stronger belief in its accuracy. So our belief in technology made us attempting a lot of medication error and harming our patient. End user of technology, nurses who that relies on ADC display that list medication to be administered, tend to forget or ignore the information from the device may depend on data entered by a person. A process that may appear to be wholly automated are often dependent upon human input at critical point and thus require the same degree of monitoring and attention as manual process. So these two phenomena, which are the automation bias and automation complacency, affecting our decision making as individual, as a healthcare provider individual, as well as teams, and offset benefit of technology. So decisions that are not based on thorough analysis sometimes lead us to be biased and having a big trust in technology. And an automation bias, omission error take place when users rely on technology to inform them of problem, but it does not. Excessive dose writing for a warning. Thus, they fail to respond to a potentially critical situation because they were not prompted to do so. Automation bias commission error occurs also. If the omission error occur, also commission error might occur, and omission mean not giving the dose or the medication with a specific time that the patient is on need. Commission, giving extra dose, giving the medication more than needed, or if it's stop or hold. Information providing by technology, this could be solved. Delanton incident, there were 2 errors caused by automation bias. The first error was when pharmacy staff member accepted diltiazem as the correct drug in the pharmacy order system. The second error occurred when the nurse identified the discrepancy between ADC and the medication administration record, but she trusted the information in the ADC display over that handwritten entry on the computer-generated mark. So continuation on automation bias, health-related studies on automation bias, complacency, clinician overrode their own correct decision in favor of the advice from technology, and 6 to 11% of a time, and the risk of an incorrect decision increased by 26%. The technology output was an error. The rate of detecting technology failure is also low. In one study, half of all users failed to detect any of technology failure introduced during the course of typical work day. Important alert did not fire, presentation of the wrong information, or recommendation. So causes of automation bias and trusting technology or automation bias are thought to result from 3 basic human factors. A human decision-making tendency to select the pathway requiring least cognitive effort, which often result in letting technology dictate the path. The factor is likely to play a greater role as people are faced with the more complex task. They might have multitasking, heavier workload, they become fatigued from having a lot of shift, common phenomena in healthcare. People often believe that the analytic capability of technology is superior to that of human. That's our belief sometimes. which may lead to overestimating the performance of these technologies, such as evaluating a bad staff who is not performing that very well, and overestimating and underestimating the other staff who's working hard. People may reduce their effort or shed responsibility in carrying out a task. When an automated system is also performing the same function, it has been suggested that the use of technology convinces the human mind to hand over task and associated responsibility to the automated system. The mental handover can reduce vigilance that the person would demonstrate of carrying out particular task independently. Other condition is the experience. There is conflicting evidence that the effect of experience on automation bias and complacency. There is evidence that reliance in technology is reduced as experience and confidence in one's whose own decision increases. It has also been shown that increased familiarity with technology can lead to desensitization, which may cause clinician to doubt their accepting inaccurate technology-derived information. Thus, automation, bias, and complacency have been found both naive and expert users. Perceived reliability and trust in the technology. While once believed to be general tendency to trust all technology today, automation, bias, complacency are believed to be influenced by the perceived reliability of a specific technology based on the user prior experience with the system. So automation is perceived to be reliable at least 70% of the time. People are less likely to question its accuracy. Confidence in decision as trust technology increase automation bias, and users are less likely to be biased if they are confident in their own decisions. To highlight benefit and recommendation of utilizing technology, there are safe practices, recommendation, and the use of technology is considered high leverage strategy, optimize clinical decision making, but only the user trusts the technology closely matches the reliability of the technology itself. Therefore, the following strategies, which are improving the reliability, supporting the clinician to more accurately assess the reliability. So you can see here the low leverage strategies or system. Human reliability is the low leverage. Medium leverage, depending a little bit on system and human, and high leverage mostly depend on the system. So most effective and hardest to implement, the high leverage. Least effective, easiest to implement is the lower leverage. So be more careful. Available information, education program, rules and policies are low leverage. Warning alert, reminders, checklist, redundancies and standardization protocols, medium leverage. And the high leverage is forcing function, barriers and fail-safe, automation and computerization. And address vulnerability. So we can be proactive and doing our risk assessment regarding the quality and safety of the process that we have it in our hospital. So failure mode effect analysis, which is abbreviated here as FMEA, for new technologies to identify unanticipated vulnerabilities and address them before undertaking facility-wide implementation. Also, we need to encourage reporting of technology associated with risk or issues or error. Limit human-computer interfaces. Organizations should continue to enable all technology to communicate seamlessly, thereby limiting the need for human interaction with the technology, which could introduce errors. So design the technology to reduce over-reliance can affect user attention and how they regard its value and reliability. For example, the autocomplete function for drug names after entering the first few letters is a design strategy that has often led to selection of the first but incorrect choices provided by the technology. Requiring the use of 4 letters that generate a list of potential drug names could reduce these types of error, rather than using 3 letters and have confusion and incorrect medication. To cite another example, the studies have found that providing too much on-screen detail can decrease the user's attention and care, thereby increasing automation bias. We need to provide training about the technology involved in the medication use system, not only to certain healthcare provider, we need to have it for all healthcare providers involved in the medication use process, which is prescribing, administration, dispensing, storage of the medication, include information about the limitations such as technology, as well as previously identified gaps and opportunities for error. Allow trainees to experience automation failure during the training, technology failure to issue an important alert, discrepancies between technology's entries and handwritten entries, and autofill or autocorrect errors, incorrect calculation of body surface area due to human error during input of the weight in Libra instead of kg. In the United States, they are using pound in order to weigh the patient, and in other countries that they are using the kg, which is the safest. Experiencing technology failures during training can help to reduce error due to complacency and automation bias by encouraging critical thinking when using automated systems. Allowing trainees to experience automation failure may increase the likelihood of recognizing these failures during daily work. We need to reduce task distraction. Although the easier said than done, leaders should attempt to ensure those using technology can do so uninterrupted and are not simultaneously responsible for other tasks. Automation failure are likely to be identified if the user is required, multitask, or otherwise distracted or rushed. Pharmacy and nursing ensure those involved in the double check process can do so in uninterrupted and are not simultaneously responsible for for other tasks. Automation failure are less likely to be identified if the human monitoring the automated output is required to multitask. Establish standardized process and address identified medication discrepancies, including verification of the original prescription order before medication administration. The manual verification counteract automation complacency that can occur with technological output from the medication use process in order to assure our system is working the right way with the right calculation that we send it to them. Part of the verification process should include assessing the appropriateness of the medication based on the patient medical history and the treatment plan. So in pharmacy and nursing, when selecting medication from ADC, compare the ADC display with a MAR to confirm the accuracy of order entry and transcription. Locating ADC in areas where nurses have easy access to patient marks will support the process. In conclusion, technology plays an important role in the design and improvement of medication system. It must be viewed supplementary to clinical judge, although its use can make many aspects of the medication use system safer. Healthcare professionals must continue to apply their clinical knowledge and critical thinking skills to use and to monitor technology and to provide optimal patient care. So by the end of this presentation, I would like to hear if there is anyone having a question, and I would like to thank the Patient Safety Center for allowing us to share this experience and knowledge with others. Dr.
Thank you, Dr. Dalia, for the interesting topic. All our guests, if you have any question, please, you can post it in question. I think we have one question. No, unfortunately, but you know, Dr. Dalia, I have one question. Today, you introduced for us all the role of technology to prevent the medication error. My question, during the transition state or when we apply any new technology, is there any precaution we should take it as a pharmacy staff or hospital staff to avoid any error? Because if there is anything new will apply, for sure there will be error. So how can we avoid it? Or can you please give us tips how can we avoid this during
there is a quality tool that we need to use it, or safety tool, such as the failure mode effect analysis, which is not a reactive action, it's a proactive. Before having a new technology or implementing a new device within your hospital, you need to know your situation. You need to study your population. You need to study, you need to assure the skills and knowledge and experience of your staff. And you need to sit in one table with your expertise from at all levels, pharmacists, nursing, physicians, respiratory therapists if it's needed. Everyone involved in this technology should be aware about it, and in a middle management level or in the leadership level, frontliners. And in addition to that, we need to talk about this technology and anything having advantage, disadvantage. So for example, if you will implement smart pump, you need to be ready with your drug library. You need to know your maximum doses. You need to assure where you are, how you will implement it. You will have an internet connection for all of this. It's a Wi-Fi working. Is your Wi-Fi will help in that. You will have a good connection, understanding, maintaining these devices. You would be able, do you have the resources and the money in order to maintain it every, for example, 1 year or 6 months? All these questions should be on the table and to be answered before implementing anything, because sometimes you will end up with having hundreds of medication errors as a result of implementing technology that is not compatible with your system, or your staff is not aware about it or cannot understand it. Hopefully I answer your question, Dr. Anouf.
Yes, thank you, Dr. Dalia. I have another question from based on Sibahi MMU standards, how we can utilize the technology to reduce potential and actual medication error in dealing with LASA medication and HAM as well.
Okay, actually, we have our national standard, which is SIBAHI, and the strategies for a high alert medication, look-alike, sound-alike medications, very clear in their standards. So we need to use a strategy within the process of medication use. And for high alert medication, you can identify it with auxiliary label. However, if you have an automated dispensing cabinet, you can add as a pop-up or alerting the healthcare provider at the time of dispensing or at the time of administration, taking the medication from ADC, automated dispensing cabinet, that is a high alert medication. Other thing that I like to talk about it, for example, having a neuromuscular blocking agent in your fridge and you want to withdraw this medication from your ADC, you need to have an alert or no notification saying that paralyzing agent, it might cause respiratory arrest, patient must be ventilated. All these notification which is needed for identifying these type of medications. In regard to the look-alike, sound-alike medication, you will identify your list of look-alike, sound-alike medication annually from your medication error report. When you identify it, of course, if you are in America, you are different than Saudi Arabia because you have different products, different companies. And within the technology, you can apply using the Tollman lettering in order to identify these medication from other regular medications. And by that, it will be helpful. And I've been asking some physician, you are aware that there is a capitalized letter, Tollman letter, and there is a uppercase under lowercase with some of the medication? They said, yeah, we are aware about it, and it's available in the look-alike, sound-alike medication. So it's a good strategy to be used.
Yes, thank you, Dr. Dalia. Two more questions. What tool do you advise us to use while downtown to assure medication safety?
Can you repeat the prescription?
What's the tool do you advise us to use it while downtime to assure medication safety? He asked about when there is downtime in the system.
Technology.
Yes. How can we avoid the medication error?
To try to focus in the high alert medication that might harm our patient by assuring that there is independent double check and assuring that this medication will not be taken out from the pharmacy unless two-person professional healthcare provider is entering this dispensing this medications. Even at the time of administration, you need to assure that. In addition to having the independent double check, you need to check the labels, even if it's handwritten in the downtime. Sometimes there are hospital, they are ready and preparing some ready labels for printed before any downtime, so they can utilize it at the time of the devices is not working. And you need to have your drug information resources available in order to ensure that you are not exceeding the maximization drug interaction.
Yes, sorry about your voice. Dr. Dali, if you allow me, also in downtime, we should do a drill as much as we can to assure that all our process is avoid error. When we have technology, sometimes we forgot the manual process, so it might lead to error. At that time, I think we need more training whenever the downtime will happen. I don't know. What do you think, Dr. Dalia? Dr. Dalia, are you with us?
I lost your voice, yeah, Dr. Renouf. Yes.
No, sorry, I have intervention with the question. Yes, it was like comment that we need to to do more drill on the downtime, because it might happen. Am I right? Yeah, during our practice, we faced a lot that downtime it happened, but when we have preparation, we prepare our team well, that we will try to avoid the error that it might happen.
You are absolutely right.
Yes, I have, if you allow me, I have one last question. Can RFID technology be utilized to decrease medication error?
What was the question?
RFID technology.
RFID?
Yes.
Medication. Thank you for the excellent presentation. To be honest, I can communicate with the person who is sending this question in order to know what is this abbreviation. And as you know, prohibited abbreviation is not allowed in medication safety. And
Yes,
I can, to be honest with you, I don't know RFID. It's related to what? I would be happy to answer this question. If there is any chance, Dr. Renouf, to have the number of this participant.
No, Doctor, you can communicate with him through the chat, and all our staff will help you and support you on that.
On that, okay.
I think no more question. At the end, on behalf of Saudi Patient Safety Center, I would like to thank you, Dr. Dalia, so much for the interesting topic. And I would thank to all our audience for their attendance, looking for welcoming them again in our next webinar. Thank you.
Thank you, Dr. Renouf, and I would like to thank the Patient Safety Center and WHO. Thank you very much.
Thank you. Thank you, Dr.